Go back. Okay, that didn't go to where I wanted it to go. That was not what I wanted. I'll go and find the beginning where we want to start. Okay, come. Quick revision there for you. Okay. So, can you just confirm that you can see this? Somebody could just confirm that they can see it?
Right.
Good.
Yes, Prof, we can see.
Okay, so we're talking about how we might use the MPS. So because it has a high negative value, this is a little schema that was set up in one of my previous hospitals about how we would work with the cardiologist. So in patients would turn up with a risk and be assessed by the cardiologists. And if they were at high risk of MPS, their patients would tend to go on to have coronary angiography. Low risk, they tend to go and have an MPS and will probably head towards medical treatment if positive. Of course, there were patients who decided to sit in the middle, and then they would just literally probably end up by having all the tests done, just to try and define the risk a bit. So this is a slightly old-fashioned study, but it shows very nicely a very nice inferior wall ischemia. And this is the kind of patient who would be has a single territory, and your risk assessment you would consider to be low to medium risk. This patient will probably end up having medical treatment and not surgical treatment or a stent. But where you have decided that you're going to do surgical treatment, there is some quite good news, because in fact, what is really the key to survival in cardiac disease is the ejection fraction. It's how efficiently your heart is working. So this is a study, a fairly old study, looking at the effect on ejection fraction of doing a CABG, and shows that there is a significant improvement in ejection fraction in most patients. Now, in some patients that doesn't happen, and this is thought partly to be due to the fact that the heart is just too damaged. It doesn't matter if you revascularize it. But in the general trend is that there's an improvement in ejection fraction. This is 6 months apart. And that would reflect remodeling of the heart after revascularization, which then improves ejection fraction. So where do we have our best role? Are we gatekeepers for angiography? Do we work in things like diabetes well? Because diabetics tend not to be able to exercise very well. What about women, or in things like pre-renal transplant? Well, the answer to that is that we're pretty good in all of those. So let's have a look at a bit at diabetes. There's been several reviews of issues with diabetes, and the problem in diabetics is that because they not just have vascular disease, but that vascular disease results in denervation. They can actually have things like MIs without any pain. So there was a very nice review of 116 patients who have type 2, that's adult onset diabetes, and 15% of these patients, which is a significant proportion, had a change on their MPS, but 10% of these patients had never had a history of chest pain. So they were either having angina or they had had a heart attack, but without chest pain. And it was recommended that any patient who was unable to maintain HbA1 at less than 9% should be considered for having fairly regular, maybe every 2 to 3 years, MPS study. The Open Cardiac Journal, there was a paper from 2014 and looked at 471 patients with diabetes, but no symptoms of coronary artery disease again, so no chest pain, followed up for 3 years. And if they had a normal MPS, then their death rate from all causes was less than 1%. If they had an abnormal MPS, their death rate increased to about 2%. So an MPS pretty well predicts also what's going to happen to these patients. Now, 2% may not sound very much, but over 5 years, that's 10%, which is beginning to get a significant amount. So, and if they had symptoms as well as an abnormal MPS, and those symptoms tended to be shortness of breath because they weren't getting chest pain, then death rate definitely went up to 2% per year. So the MPS is useful in patients with diabetes. Now, this is one of our patients who has diabetes. This is a 65-year-old female without any symptoms at all. And you can see again the inferior wall here, that there is some change between stress and rest. It's not gross, but it's definitely there. And also this patient's a bit dilated at rest. So these are the kind of pictures we get. And the other thing you'll notice is the uptake of the tracer can be quite patchy in a diabetic. We felt that it being a female, inferior attenuation was unlikely. So this was probably a little bit of a mixture of a bit of ischemia and previous basal infarct. So what about women in general? Well, when I went to medical school, I was told that women didn't have heart disease. My cardiologist, who ended up as a professor of cardiology, told me point blank, never, 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 ever consider women having heart attacks. No MIs, nothing. However, he couldn't explain why it was still the major cause of death in women across Europe. And one of the problems is that symptoms can be somewhat atypical. And one of the examples, for example, is they could be related to eating. So patients who eat may get chest discomfort, and they were told it was just indigestion, whilst we think it may actually be what we call splanchnic steal of blood. Now, the risk factors of diabetes, hypertension, and obesity generally are slightly more common in women over 50 than it is in men over 50. There's also racial and cultural factors which are interesting in patients of African and South Asian origin. And they seem to have more problems in terms of particularly diabetes, hypertension, and obesity than a European population. But this could, I'm not talking about North American Europeans, by the way, who definitely have more obesity and diabetes, but European Caucasians. But this may be explained by diet and activity. And there's a very interesting little study that was done which compared South Asians who lived in Pakistan and South Asians who lived in the UK. And what they did is they looked at their age, gender, and they compared them. And in Pakistan, they had less heart disease than they did in the UK, suggesting it wasn't a genetic factor. But what happened was that South Asians in the UK just lived in a more affluent society, so they could afford to eat more meat, particularly lamb, which has got high cholesterol, and smoke more cigarettes. So they put themselves at higher risk. Now, generally, we know that, bizarrely, in most diseases, women present earlier than men, but in heart disease, probably because they're less aware, women present later. Also, they may present when they have more other problems like arthritis, and often they're told they have arthritis in their chest, and they get sort of put off presenting. They may have different response to physical stress. They may have more problems exercising because they have arthritis in their legs and knees. And the atheroma itself appears that it might be of a different nature, and we have a higher rate of diabetes independent of that. So this was a 78-year-old female who had been relatively fit, a non-smoker, and she only got chest pain when she ate. So she was told she had diabetes and she was given antacids, but it wouldn't go away. She had endoscopy that was negative, so somebody decided to do an MPS study. And as you can see, she has a very significant ischemia in her anterior wall. Her anterior wall just isn't there. Neither is quite a lot of the lateral wall stress. She's only relying on her inferior wall stress, though she has a relatively normal myocardium at rest, though she has appeared to have had an apical infarct. So this patient, who has no classical symptoms at all, has got very extensive ischemia. Now, other people said, well, then it doesn't make any difference because if women have positive studies, then they still live longer. Well, that's not true either. So this was a study done by Schwer et al., looking at both women and men with abnormal MPSs, and to be honest, it made no difference whatsoever. Both the ischemic volume of ischemia on the MPS and the ejection fraction had pretty well equal event rate. The only thing which was an issue was in women with low ejection fractions and more than 10% of their heart abnormal on an MPS. They had an annual event rate of nearly 40% compared to just 25% with men. So, in fact, an abnormal MPS may carry even more prediction of heart problems in women than men. Then there's this issue about atheroma, and there tends to be a difference in the way that the atheroma presents. So in men, the atheroma tends to be short and appears to have a different effect on blood flow in small arteries, and it can be much more easily treated by either stenting or CABG. In women, atheroma tends to be less severe, but over a longer part of the vessel. And this results in a more diffuse change in flow that may not be dealt with well by stenting or CABG, and may require a significant amount of medication. But obviously, when we're doing MPS, we're looking at this end flow, so we can predict those changes in perfusion. So coronary angiography will say, it's only 50% stenosis, it's not significant, but the MPS may show significant changes. And we know that the MPS is very much better predictor of outcomes. So again, this is another patient of ours. This patient has a female patient with extensive myocardial perfusion. So only the LAD has got reasonable flow. So this patient was presented to us with equivocal changes on angiography, but you can see that nearly 2/3 of the heart is ischemic. This patient has a very poor prognosis unless they have significant treatment. What about renal transplant? Lots of us do MPS's pre-renal transplant. We find it's a very good staging process. Now, many patients who are on the renal transplant list are also diabetics. They have the risks of diabetes. So people have looked at patients with renal failure. The problem is that when you have renal failure, a few things happen to you. You get hypertensive, which is a risk, and you get hyperlipidemic, which is a risk. And this is completely independent of having those conditions. And there were 244 patients who were looked at who had no history of any cardiac events before they had a renal transplant. But 16% of these either suffered cardiac arrest, which was irreversible, or significant MI in the 90 days post-transplant. So these patients going into operation, being told that they'd have no risk factors, and 16% of them had a significant problem post-op. So this is a patient of ours who was 39, not diabetic, just had renal failure, on dialysis, no history of chest pain. And this patient, as you can see, has got a big infarct in their apex, and they've got a very poor perfusion in what's left of their anterior wall. So this patient had no history of chest pain at all, but had a history of obviously clearly significant infarct and probably some degree of anterior wall residual ischemia. So this patient needed really to be reassessed before going into transplant. They will be at high risk of having a cardiac event during transplant. So that's the groups that we're good at. What other areas can we look at? Well, hibernation is an interesting area. This is an area defined as chronic ischemic tissue. And this tissue is hypoxic. It's not able to burn lactic acid through the Krebs cycle. It can only use the first part of the glucose metabolism, which is phosphorylation. And that is very glucose dependent. And the hibernating myocardium can get some perfusion, but it's not very good at contracting because it can't generate enough energy. So it will have some flow on the MPS, but very poor movement when you gate the study. So this is a patient who has got apical septal hibernation, and you can see here that the lateral wall has got reasonably good perfusion and some movement. The anterior and anteroseptal wall does have some perfusion, but no movement at all. And the total ejection fraction is only 31%. And this is because this area is hibernating. The inferior wall is probably infarcted and irreversible. So this is an area of great interest. So you can get a clue about hibernation from looking carefully at both the perfusion and the gated study, though you may want to go on and do a viability study with either thallium if you've got SPECT or FDG if you have PET. So gated studies themselves are very useful in terms of prognostication, and we know that ejection fraction is important. So if you're below 50%, it's abnormal. Below 40% means that there's some reduction in LV function. By the time you get to 30%, the patients are often breathless. If they exercise, by 20%, they're breathless at rest. And by 10%, if you get to 10%, you're still alive, then you either need to have a cardiac transplant or you're going to die. And ventricular aneurysm makes it more difficult. And in ventricular aneurysm, you can also see, because you get sort of splaying of the walls. So the walls sort of go, instead of going together, they go out, particularly in the stress studies. You can see this time the rest is on the top and stress is on the bottom. So this patient's obviously got extensive infarction, but you can see also at stress, and this is just with adenosine, that the heart appears to sort of go outwards towards the apex, so the apex is missing. And that's suggestive in an aneurysm, though that would need to be checked by echo or Mugger. This is a study from the US looking at death rate related to ejection fraction. And you can see the annual death rate goes up significantly as the ejection fraction drops. And once you get below 40%, you're getting significant rates of death rate. So the ejection fraction from a gated study is really important. Other problems that we can get with MPS is attenuation. And as we heard before, in men it affects the inferior wall, in women the anterior wall due to breast tissue. You can use the gated study to help you with that, but also we can use CT attenuation correction, and later on I can show you some changes with PET. So how do you know if the patient's got attenuation? Well, the best thing to do is look at the planar mode, do the cine run, and see if the, for example, breast tissue diaphragm affects the counts. And you may need to look at it at different angles to see that on the cine. Also, it should be in the same position at stress and rest. But that in women depends on the breast being in the same position. So however the breast is supported at stress should be supported at rest. So normally we ask for the women not to wear a bra so that the breast tissue can basically move out of the way of the heart. In older women, breast tissue can move quite significantly, so you can get it to the side away from the anterior wall. One of the problems is always when you've got a fixed defect on an MPS, is it due to an MI or attenuation? And a gated study may help you with that, but also attenuation correction. But be aware, because you have to be very careful, because you can overcorrect with attenuation correction, and this can result in new artifacts. So you've got to be very careful, particularly if you're not used to reading these studies, what the effect of attenuation correction is. So this is a gated study. Is it attenuation? There's here where you can see the stress image and the rest image in diastole and systole. You can see there's a defect there, but that defect's not so clear in the stress image. Here in the rest image, you can see the diastole. There is a bit of flow there. Sorry, this is stress and rest, which is an apparent defect, but in diastole, you can see there's a defect which isn't there in systole, but diastole is when you get flow through coronary arteries. So looking at the carefully at the study, you can see that this area is short of blood, and that is a real thing and not attenuation. So you can look at the scan, the gated scan carefully, and that tells you a lot of the information. Here we have a patient with persistent ischemia. You can see it's even bigger here. So this is the defect at stress. At rest, it doesn't look much different. But when you look here in the gated stress study, you can see there's a big defect in the flow diastole, which is when you should be getting your maximum flow, which is not there at stress. So this again helps you to see that this is a significant difference. Again, we can use quantitative gated studies such as QGS. We can analyze both the ejection fraction, diastolic and end-systolic volumes. We can provide imaging of wall motion, and we can look for reduced regional wall motion, which could be due to ischemia, such as hibernation or stunning or infarct. And one of the issues we have, of course, is by the time you're gating a three-dimensional object, you've got 4D, which is 3D plus time, and you're trying to plot that onto a 2D image. Therefore, the images get quite complex. This is a bullseye plot. This is a Cedars-Sinai bullseye plot. You can see it's maybe, you can see the stomach uptake in the rest scan. And this patient is relatively normal, but you can see how difficult it is to measure it. But it does give you very good volumes and ejection fraction, 67%. So you can get quite complex information off of your computer and use as much information as you can when reporting your MPSs. So the latest thing is that people have started to use attenuation corrected SPECT to do quantitative work. So originally we were told you can't quantitate anything with SPECT, but that's not entirely true. There's various modeling now which enables you to get the equivalent of an SUV from a SPECT study, which correlates about 98% with what you get from PET. So then you can start to use your SPECT CT MPS to quantify stress myocardial blood flow, the rest myocardial blood flow, and the flow reserve, which is one minus the other. And it's the flow reserve which is now considered to be the sort of golden measurement of ischemia. So here we have, this is actually from a company website. This is, I think, from Siemens, showing how you can quantify the myocardial flow rate. And you can look here where you've got the stress image, the rest image, and using quantitative SPECT, they can get an SUV. And this is the stress flow, the rest flow, and the quantitative reserve. And this, you can see here that there's very poor reserve in the here in the inferior wall and some of the lateral wall. And this is the coronary angiogram confirming those changes. One of the big advantages is using this is that you can see when the patient has balanced ischemia. So one of the problems with balanced ischemia is that all three vessels are abnormal. So the MPS can look normal at stress because you've got equally reduced flow through all your vessels. By using these quantitative techniques, you can see here in this patient who does have, see even some disease in the LAD, though most of the diseases are in these two vessels, you can see that you can quantify and see these abnormalities. So I think it's an interesting area, but these machines and programs are quite expensive. And if you're going to do that, you have to decide you're not going to be doing PET, really, because PET, you either have to invest in PET or in these quantitative CT machines. The machines are almost equal in price. So the big advances haven't been in radiopharmaceuticals, but in the imaging devices. These have become much more sophisticated. But the other areas that are next are PET-based agents as well. So the advantage of single photon agents is generally they're cheaper. Things like rubidium are quite expensive. You need to buy a generator, which costs tens of thousands of US dollars. It only lasts for about 3 or 4 months. So unless you're doing lots and lots of studies, and by that I mean 6 or 7 studies a day, every working day, the generators are very expensive. The other advantage is that SPECT machines are smaller, so they may fit into private practice better than a PET machine. And obviously the problem with PET machines is they're mainly busy doing oncology. So how do you do 6 or 7 cardiac scans and do all your oncology studies? It means your machine will be busy for 16 to 18 hours a day. Then you have to buy staff to staff them, including medical staff as well. Also, obviously, technician-based agents have got a longer half-life, can be transported around more easily. So people have started to develop these dedicated cardiac cameras that they're smaller. They can even split into sort of an office space. They're optimized for patient comfort. They have dedicated software, and some of these even use new technology. So one of these is the D-Spect. Now this is a non-moving gantry that just wraps around the patients, and the detectors move back and forth to acquire the data, and very much faster than the classical SPECT. So you can get a high quality SPECT in about 5 minutes. So this is a little cartoon. So what you do is you sit the patient on a very nice chair, a bit like a dentist chair. You then have a system that wraps around the patient, and then these heads inside the system oscillate. And the oscillation gives you your SPECT data with some clever mathematics. So this is what the machine actually looks like in reality. So the patient just sits there, and then this just comes around the patient, and they just sit there quietly for 5 minutes. So you can imagine how, the camera head doesn't go over their head. It's not claustrophobic. It sits in a small space. So this is a 6-minute thallium. So normally with thallium, we wouldn't expect to get a good quality image in 6 minutes, but this is a 6 minutes for a normal patient with a thallium. This is ischemia with MIBI done in just 2-minute acquisition with MIBI. The other thing is, because you're really close to the patient, you get very high quality images. So this is the stress and the rest, where you can see very nicely infraseptal ischemia. In a very high quality image. You'll notice that the resolution of these machines is down to about 4 or 5 millimeters, not far off PET, which is very interesting. You could use more traditional gamma camera technology. This is something called a D-Spect, which is now available with a digital head, which again increases your sensitivity and reduces your resolution below around about 6 or 7 millimeters. And this is added to a CT scanner. This is with the 16-slice CT scanner, and you can get very nice images here, again, of the heart. And you can lay this over the CT that you've acquired. You can even do contrast CT and get a coronary artery CTA, and you can show the abnormality in the coronary artery and how this is related to ischemia. And all this is available in the software of these dedicated cardiac SPECT CTs. And the machine itself is much smaller than a standard gamma camera. So how do they all compare? This is some work that was done at University College London Hospital, and they compared the D-Spect with an ordinary SPECT and an ordinary SPECT with coronary with CT attenuation correction. And you can see that the two best images are the top and bottom ones. This is done with a gamma camera. This is done with a D-Spect. And you can see probably even then the D-Spect is producing better quality images than even a gamma camera with attenuation correction CT. But you can see without the attenuation correction, this inferior wall looks very abnormal. But using modern gamma camera machines and the ability to use modern electronics and computing, we can get rid of a lot of these artifacts. However, again, if you're going to buy one of these machines, you have to be basically using it full time. You can't really use it for anything else, and you need to have space to put it in. So what about PET? Well, some of the big advantages of PET is increased resolution. Now, because we're dealing with the heart, the resolution may be less important than it is in other areas. Sensitivity of the systems are useful, but the main advantage is financial. If you can get more patients through your scanner, you can make more money. So that's a big advantage if you've got PET. We do know that the CT attenuation correction on PET is very good, and that can be very useful. If you look at FDG, then you can look at the metabolism, which is very good. So FDG is the most commonly used radiopharmaceutical in PET, and still the most commonly used in cardiac PET. Uptake is dependent on glucose drive in cells, which is related to ischemia, as we explained. If you don't have enough oxygen, you have to just use phosphorylation, which gives you 4 ATPs per molecule of glucose, compared to 32 ATPs you get off the Krebs cycle. So ischemic tissue needs a lot of glucose. Now, do remember that in diabetics, you do need to keep your blood sugar below 6 millimoles per liter when you're scanning the patient. And this particularly lets you look at viability. So ischemic heart will be viable, it will be salvageable, but it will be using a lot of glucose. And this is important because you can improve ejection fraction by more than 7% on average. It shows if you can improve the ejection fraction. And FDG can find that viable portions, can find the viable bits of the heart. This was a paper published from Japan, looking at 41 patients using thallium, and then going on to use FDG to find viable segments. And they demonstrated an improvement in patients who then went on to get surgery as defined by viability from FDG, with an improvement of more than 5% in ejection fraction. This is one of our patients, and here you have a patient who has basolateral ischemia, and you can see the very marked increased uptake of FDG in that part of the wall, which wasn't moving, so it was a hibernating bit of myocardium with increased uptake of FDG. So FDG can be very useful. However, it is not a flow agent. The most common flow agent is rubidium-82, is a potassium analog. It has a very short half-life, so you have to continuously infuse it from a strontium-rubidium generator during stress. So you have to give pharmacological stress because you have to have the patient in the scanner. And normally you image for about 15 minutes. You can use adenosine or dobutamine or regadenosin as well. So how does it work? Well, 112 patients in this study had both MIBI and rubidium studies. 4 readers were blinded and compared to CABG with a stenosis of 70%. The rubidium accuracy was calculated as 89% compared to 79% for SPECT alone. And I think most of the people will agree with those figures. And it was found that rubidium was better in men and the obese. And that might be, the men might be related to the problem with the fact that women don't often have a 70% stenosis when they have an abnormal MPS, which we discussed before. So this is from their paper. This is a rubidium study in mild ischemia. And it's quite subtle, but you can see that there is some reduction in the apical anterior wall and apex, which improves at rest. So you get the resolution to pick up these quite small areas. And the image looks quite clean. There's not much background activity. So like thallium, you get a very nice clean image. And so you can get very nice quality results with rubidium. And again, you're not so worried about attenuation because of the 511 keV doesn't really get bothered by the breast tissue or the diaphragm. This was image of the year at the SNMI a few years back, and this is a patient having a rubidium on a PET CT, and the CT scan itself was done post-contrast, and then they were mapped together to show the area of, this was a stent that was put in, but it was showing that this stent wasn't really working, and you had apical ischemia, and there was also an ischemic segment down here at the base coming off the oblique obtuse artery. So you can get quite clever results with this. Looking at slices, which we're much more commonly seeing, this is from New York University, and you can see that the image quality can be much improved. You've got a classical, slightly obese patient. The SPECT image doesn't look very good, even with attenuation correction, but when you have the rubidium image, you can see it's not perfect, but it's a much better image. You can see clearly that inferior attenuation has just gone away, and it clearly is a normal study. Again, this is looking at stress and rest in a patient who has some breast attenuation. So you have this question on the anterior wall here: is this breast? Is this not? A female patient, and the question is, what was going on? Was the breast in a different position between stress and rest? Here we have the attenuated corrected, CT attenuated corrected data. again, it gives the impression this may well be a anterior ischemia, but when you do the PET with rubidium, you can see it's entirely normal, and this was just due to different position in the breast tissue. Doesn't matter for PET. 511 will get through anything, so you don't have the problems of attenuation. So this is the one-stop shop. If you have rubidium and a PET-CT scanner, so you can do everything here. So what you have, and you want to do viability. So this is everything all together. Okay, so you start off with a attenuation corrected CT scan. You then do your rubidium infusion at rest. What you then do is you then do your adenosine stress, and you do your attenuation corrected CT, and you repeat your rubidium at rest. That's the two yellow blocks, the rubidium. So you've now got your rest and stress rubidium. You then inject the FDG. The patient can go away. You do another patient. They come back. You do another attenuation corrected scan. You then do your FDG viability. Around about the best time for that seems to be about 2 hours. So you get clearance of background, and then you can do a CT angiogram. So in a day, the patient's with you for about 2.5 hours, and they have every bit of imaging that they need to work out what's going on with their hearts. Because of the problems with rubidium, and particularly the problems getting generators, people have tried to look at a fluorinated perfusion tracer. And the advantage, of course, is that if you've got fluorine, you can move it around between hospitals. You can inject the patient and scan. A little bit later, you don't need to do the acute scanning. And it would be particularly useful in smaller units. And also, you wouldn't have to try and fit in a whole day of cardiac scanning, which you do to make the rubidium cost efficient. You could do 1 or 2 cardiac scans, and the rest you could do with oncology, or etc. And there are some other people trying to look at tracers for hypoxia and apoptosis. But the one that's probably the most successful is fluoroperidase. This was in fact invented 13, 14 years ago. It's a pyridine derivative. And it has very similar properties to MIBI. The cardiac uptake is a little bit better than MIBI, about 13% compared to 4% for MIBI at most. It has a very similar distribution with MIBI, but you don't have the attenuation correction problems. So this is stress and rest images taken both with MIBI and then with fluoroperidase. I hope it has a better name by the time we get to use it. And you can see, again, a bit like the rubidium, you get a much cleaner image with less problems from attenuation. Various other tracers are in research. Fluorinated to look for classification, DOPA to look for innovation, a bit like MIBG, FDG to look for inflammation as well as for viability, F-MISO you could use to look for hypoxia, dotatate, which labels activated white cells for inflammation, and acetate to look for aerobic metabolism. Also with high quality PET scanners with 64 and 128 slices, it's very much easier to do coronary angiography on your PET-CT slice. So this is a patient who has got a problem in their heart. This is the FDG showing glucose uptake. And you can see the basal lateral wall and the basal septum has very poor metabolism. This is fatty acid showing much more normal. And so this is a patient who's unable to burn glucose properly because they've got ischemia, but they're able to metabolize some fatty acids. Sodium fluoride looks at things like high-risk plaques in coronary arteries. This is some work published in the Lancet, 40 patients, and they showed that if you compared FDG and sodium fluoride, the FDG didn't really help to work out where there was unstable plaques, but there was very good uptake of the sodium fluoride. And the advantage of sodium fluoride is no uptake in normal myocardium. And here you have a patient with some calcified atheroma, and here you have very intense uptake of sodium fluoride. You note sodium fluoride, you can see the bones very nicely. This is from Joshi's paper showing that the light blue is sodium fluoride and the dark blue is FDG. So if you look at the target to background ratio, which was done, I think they did it to the spine, I think, to spinal bone marrow for FDG and spinal bone uptake for sodium fluoride. This is the suspect plaque, which is a plaque that's about to break and cause an MI on angiography. This is a normal plaque, and you see the dark red, the dark blue bars almost the same height, so it's not really helping very much. The light blue is how much uptake you get of sodium fluoride. You can see it's much greater in the suspect plaque, so showing that the suspect plaque appears to have a much better prognostic value in finding those suspect plaques that need to be stented before they cause infarcts. This is a dotatate scan. So this is just been published, actually. It was published in JACC Imaging about 4 months ago, this work, looking at somatostatin receptors in the coronary arteries, where you have very acutely inflamed atheroma, which is just about to break, and you get uptake in both activated macrophages and lymphocytes of dotatate. And again, you don't have any uptake in any normal tissue, so you only get a signal where you've got an abnormality. We have to remember, though, there are alternatives to MPS. There's stress echo, but that's dependent on operator. Myocardial CT angiogram is probably a competitor. It certainly can replace invasive angiography, but it does mean that as those centers use more CT, we do find that there's sometimes a drop in use of MPS. Now, I have a particular interest in cardiac MR because 4 weeks ago I had a cardiac MR for reasons that I still have absolutely no idea. I was just told to turn up to cardiac MR, and I spent the most unhappy 90 minutes of my life trying not to breathe intermittently. It really is a horrible, horrible, horrible scan. And I was told that it was a quick one at 90 minutes. So they can do about 4 of those a week. So unless you have hundreds and hundreds of MR scanners, it's not really ever going to be a significant contribution. And I can tell you an awful lot of patients who've had one will never, ever have one ever again. I suppose I'll have to because I've got to be well behaved, but I'd rather never have a cardiac MR again. So people that tried to look at this, there was a paper published a couple of years back in Holland looking at MPS versus cardiac CT and cardiac MR. They looked at the pooled data of about 2,000 patients. They said that MPS was less at 61% accuracy, but a combination actually worked quite well. So if you had MPS and MR or MPS and CT, you could get about 100% right. So they were suggesting you should use a combination of 2 of these. This is a very busy slide. Well, what it was basically showing is that the combination, again, of MPS plus one of these anatomical methods would give you not only the best sensitivity, but probably the best specificity on either a per vessel analysis, which is this graph, or per patient analysis, which is this graph. So we probably always need to have 2 types of modalities, one that is anatomical, such as CT angiogram, and one that is functional. And at the moment, nuclear medicine technique still provides the best functional technique. Now, of course, if we have good perfusion agents in PET, and we have a PET CT, we can do it all in one sitting with both the cardiac imaging by PET and the cardiac imaging by CT. So total summary here is, for the whole group, is obviously we can do physical and pharmacological stress. The important thing is MPS has a negative predictive value. A normal MPS study tells you that your chance of dying of cardiac disease is very, very low. That's really important. It doesn't matter what symptoms they have. It doesn't matter what coronary angiography shows. A normal MPS means that their chance of dying of heart disease is low. It's particularly useful in those groups where other cardiac tests are not useful. That includes patients with diabetes and women. So that's like 70% of the population. You know, maybe, I don't know. Depends how many. No, that's too many diabetics, isn't it? Maybe 60% of the population. 55% of the population are women, because men kill themselves off much more quickly with heart attacks. and then 5% of the population are diabetic men. So there we are, how about that, 60%. There's a growing role for PET, but for it really to take off, we need a PET perfusion agent with F18, because only then will it really become cost efficient. And then it can compete, I think, with a lot of these other modalities. So that's it. I hope that is useful. So I'm just going to stop the recording.